We have chosen two articles. Both are related to the burning topic these days, which is COVID. Before we start, this is a disclaimer. This activity is we are organizing because of unrestricted educational grant from the Cheesy Pharmaceutical. And let me say that Cheesy has no input on the selection of the article or in the preparation of these slides. So they are just cooperating us in spreading this. Now, we are going to discuss a study by the title, A Prospective Study of 12 Weeks Respiratory Outcome in COVID-19 Related Hospitalization. Now, we all know that COVID affect lung, most common organ that is involved. And what is the COVID situation till yesterday? You can see globally, 166.35 million people have been affected by this pandemic, and 3.5 million people have died. I think all of us in our lifetime has not faced any such infectious diseases killing so many people, 3.5 million. And in Pakistan, 897,000 cases have been reported so far, and over 20,000 people have died. And as you can see, till 16th May, about 3,008,036 people have been vaccinated. So it's a real big issue all over the world, including Pakistan. So in this study, which was done at the University of British Columbia, Vancouver, Canada, this is a hospital-based study. It was a prospective study, and in which they included a cohort of patients, and then they tried to see what were their situation at the end of 3 months, what were respiratory outcomes. Being a respiratory physician, we are always interested in knowing the long-term consequences of COVID infection. We are all seeing it, but to document it requires some time, efforts, and of course money. So we are going to discuss the method, the results, what were the PFT abnormalities at the follow-up, and what were the respiratory outcome. So we want to understand the long-term respiratory outcomes from COVID infection, and we wanted to see that what are the clinical predictors of poor respiratory outcomes, direct evidence-based management of post-COVID respiratory care. Then we also wanted to look at the clinical feature, pulmonary function abnormality, and radiological outcomes in patients assessed 12 weeks. So all patients who were admitted were assessed at 12 weeks after the symptom onset in a prospective cohort of patients with COVID-19. Examine clinical predictors of persistent dyspnea, reduced lung function, and radiological abnormality. So this study tried to see, is there anything we can predict which patients are going to have reduced lung function, which patients are going to have radiological abnormality. As I said, this is a prospective consecutive cohort, adults with COVID-19 patients who were hospitalized from March to May 2020 with laboratory confirmed cases of COVID-19, and they were assessed 12 weeks following symptom onset. And the investigation they did at 12 weeks included detailed pulmonary function testing, 6-minute walk test, and high-resolution CT scan of the chest. And anybody who had less than 80% of predicted were considered abnormal in the PFTs. And the co-primary outcomes were dyspnea and diffusion capacity of the lung for carbon monoxide. And the secondary outcomes were total CT score. As you know, CT score, you have a mechanism to see the percentage of lobes involvement, and then you give a score. And each measured 12 weeks after the symptom onset. This is a small study. It's not a very big study. You can see they received 85 referrals, and then 16 people were excluded because 3 diseased, 6 declined appointments, 7 are able to reach. So 69 patients they selected, assessed in the clinic 12 weeks after the symptoms onset. And 9 were excluded because 5 4 declined consent, and 5 were only seen as a telehealth rather than a physical exam. So 60 patients were included in analysis. So its number is not that huge, but we'll try to see what abnormalities we saw in them. So they used multivariable linear regression model. They looked at oxygen requirement as a proxy for disease severity. So number of days any person was requiring oxygen was used as a proxy for disease severity. If people were requiring more days of oxygen, then it was considered as a severe disease. They used that as a marker of disease severity. Then they looked at 4 models. One was model was 1 to 3. They looked at what is the association between duration of oxygen supplementation along with University of California, San Diego dyspnea score. I mean, we are more used to St. George's dyspnea score, but they used, which is also a very standard questionnaire to measure dyspnea, University of California, San Diego. And they also compared it with the total CT score respectively. In the model 4, they looked at the UCS dyspnea score at follow-up. Could that help us in the decision for further investigation? Those patients who are still having dyspnea at 12 weeks, could they guide us what further investigation need to be done? The number of days on oxygen supplementation during the acute phase of COVID-19 was not associated with dyspnea score at follow-up. So that is interesting, that you cannot predict. Someone who is having a longer days of duration may not necessarily have more dyspnea at 12 weeks follow-up. But there was a strong association they found between DLCO predicted and total CT score, along with the those people who had longer duration of oxygen number of days, they had abnormalities in DLCO as well as in total CT score. So if you look at this chart, after adjusted analysis, if you look at the first thing that you looked at is the University of California, San Diego, score of dyspnea, in which they compared dyspnea with the days on oxygen supplementation, and they found it was not statistically significant. As you can see, the p-value. It was not statistically significant, 0.05. It was less than, more than that. But other 3, like someone who had more days on oxygen supplementation, then they are more likely to have DLCO abnormalities at the end of 12 weeks. This is statistically significant. Again, if you have more days on oxygen, during hospitalization or after discharge, then at 12 weeks, you are more likely to have a CT score, higher CT score than someone who required less days of oxygen. So there was a good correlation between them. And then again, they looked at those people who had dyspnea at 12 weeks. They also had DLCO abnormality. So you can predict someone who has a dyspnea at 12 weeks is more likely to have diffusion capacity of carbon monoxide abnormality. So as I said, this is 60 patients. It's a small number. Median age was 76 years. 68% were males. And dyspnea was the most common feature. We all know in COVID, lungs are the most common organ affected. 77% of the patient presenting feature were dyspnea. And these were the subjects. You can see that there were few ex-smoker, ever smokers there, but dyspnea, cough, and in comorbidities, people had 35% hypertension, 22% diabetes, then chronic pulmonary disease, coronary artery disease, malignancy, chronic kidney disease. The usual cases that we also see in our hospital who come to us with COVID. Average duration of stay of their patient was 10 days. Patient requiring oxygen supplementation the number was 59. It was 46 patient out of them did require oxygen supplementation, and in number as far as number of days they required oxygen. So 9 days were the average number people required oxygen, and need for mechanical ventilation was there in about 20% of the patient, and duration of mechanical ventilation was average was 8 days. So if you look at the PFT abnormalities, the follow-up, at least one PFT was abnormal in 58% of the patient. That's a very high number. One PFT abnormality, either FVC, FEV1, or percentage. So at least one abnormality was present in 58% of the patient. Abnormal DLCO was present in 52% of the patients. So half of their patient had abnormal DLCO present, with 45% of these patients also having abnormal total lung capacity, indicating concurrent restrictive ventilator defect. Airway flow obstruction was present in only 11% of the patient. That could be due to the presence of COPD or asthma, as some patients were ex-smokers there. And 7% of the patient had oxygen saturation less than 88% at the end of 6-minute walk test, and all of these patients had abnormal DLCO. So PFT abnormalities at follow-up, 55% of the patient has greater than 10% of lung volume affected by either ground glass or reticulation. This is the, and then more likely in those who receive mechanical ventilation or oxygen supplementation. And 83% of the patients who had CT abnormalities had ground glass, 65%, and reticulation, and 12% had no imaging abnormality on the CT scan, and they did this HRCT at 12 weeks. So people had significant persistent abnormality even at 12 weeks. You can see all the respiratory function tests, PFTs abnormalities, plus cough was present, dyspnea was present, and so significant abnormalities were present at 12 weeks after the symptom onset. And if we see the CT scan that they did at 3 months, they found significant people had ground glass score, reticulation was present, and if you count both ground glass and reticulation, then 13 out of 59 patients had abnormalities. So if you look at this chart, if you just concentrate on the right side, this is a CT abnormality. You can see if you just count both reticulation as well as ground glass, then about 25% of the patient had abnormalities even at 3 months. So that is very, very significant number, that 25% of the patient had persistent CT scan abnormality, and there comes a lot of questions that what we should be doing to prevent this thing still present at 3 months. We still do not know, should we have continued steroid for longer period? Should we have continued any other medication to reduce the chances of these CT abnormalities at 12 weeks? And this is what mild COVID would look like, from CT point of view. This is mild, and this is what you call typical ground glass peripheral opacities you expect to see in a moderate disease. And this is someone with severe disease. At the moment in our hospital, we have several such patients at the moment who are on various respiratory support, non-invasive ventilation, non-rebreathing bags, some on ventilators, and we are still struggling for, many are there for over 3-4 weeks, but still not coming out. So what is the bottom line? What is the thing that this article tried to tell us? That even patients with minimal symptoms may have objective abnormality post-recovery from COVID-19. So this is very frightening, that even with minimal symptoms may lead to some permanent damage to the lungs. More than half of the hospitalized COVID patients have lung function and chest imaging abnormalities 12 weeks after symptom onset. So half of the patient had abnormality either on the CT scan or lung function. That's a huge number. And the abnormal DLCO and ground glass abnormality in CT were more frequent abnormality at 12 weeks. And here comes the importance of preventive strategies. It is easier to prevent this than to wait and see such abnormalities. Significant number of people would have permanent lung damage evident on either CT scan or pulmonary function test. So what are the strength and weakness of the study? The strength is that very few studies have really recorded, in the subsequent follow-up pulmonary function test and CT scan. So this study has highlighted that a significant number of people post-COVID at 3 months would have abnormality detectable, and it's not a mild disease at all. And the study has raised alarm on the serious damage after COVID infection and what can be done to reduce this damage. And but the weaknesses are that's a small sample size. I'm sure in Pakistan we can all do a similar study and publish this data in thorax, and we'll be happy to get this study from Pakistan. There is a acute shortage of such study from low-income country like Pakistan and other Asian countries. So thorax would like to publish such studies. And there was also, weakness on this study that 25% of the patients for one reason or the other were excluded because of some reason or the other. So in the same issue of thorax, there was another study I just wanted to briefly touch before I asked Dr. Irfan to take over. Now, this is a study, it was, the previous study that we presented was in the inpatient. And this is a study in the same issue of thorax. And this is a study is an outpatient. These patients were not hospitalized. These patients were managed on the outpatient basis. They are mild cases. Yet, this study has, looked at symptoms at 1.5 to 6 months after symptom onset in non-hospitalized subject with confirmed COVID-19. So when they looked at in the follow-up outpatient, these patients were never admitted. 16% reported dyspnea, 12% still reported loss or disturbance of smell, 10% loss and disturbance of taste. I was surprised when one of the patients mentioned the other day that after 3 months, still he can't smell. So this is, some permanent damage is taking place to vital organs in the body. So then they looked at, is there anything that they can predict why these people have such permanent damage done? And when they looked at, and they found that those people who had more comorbid conditions, like they had diabetes or they had COPD or their other more comorbid, then you are more likely to have persistent symptoms. Or if you have more symptoms at presentation, like you have GI symptom, you have a neurological symptom, you have lung symptom, then you are more likely to have persistent symptoms even after several months. So in conclusion, this study has shown that persistent symptoms were common after COVID-19 in non-hospitalized patients. So this is my final slide, ladies and gentlemen. We have seen as a pulmonologist, as a respiratory physician, we saw in these two articles that both inpatient and in outpatient, significant damage is taking place to the lungs of these patients. And a lot of research need to be done how we can prevent this lung damage. But take-home message is prevention. Why not prevent this disease? This infectious disease is preventable if we all could, do physical distancing. We could all wear masks when we go to the public place, and we all get, our vaccines. There is a lot of, misconception about vaccines in the public, And as a health professional, as a respiratory physician, we must do our best to encourage people to go and get vaccinated. So in the end, thank you very much to BMJ, for starting this educational activity. And I hand over back to Dr. Aksa. I will come back with question and answer in the end. Thank you, Dr. Aksa.